Thank you. After all, the highly detailed presentation of Dr. Selim based on methodology, I will be talking about the effect of antidepressants in bipolar depression. Before starting my presentation, I would like to show you a video recording of one of my patients. It is analysis, meta-analysis, result studies, etc. But now the clinicians are under the pressure of too much information or too much data. In my opinion, that is also a reality. We're trying to find the best publication, and we are trying to find and access data in the literature, but I have to avoid publication bias. Now I want to go back to the patient, because I'm a clinician, and based on Hippocratic oath, our objective as a physician is to assess our patient. All these studies, do they have any clinical validity? Are they suitable? Are they useful for us in the clinic, in our daily practice? For 3 years, I was involved in psychiatry.
Forensic medicine.
In forensic medicine. Everybody can carry out a simulation process, but every disease has its own clinical validity. So it's not so easy for anyone to pretend to be a mental patient. Simulation, even though it seems to be quite easy to the layman, actually it is not. You have to understand the importance of and also validity of a disease. Let me tell you that my presentation will not be very long or boring. This is the PD study, Systematic Treatment Enhanced Program. It is supported by NIMH. It's a multi-center study. About 5,000 patients were included in the study. There are many publications about this major study. It's the PD. Here you see what the PD is. I took this from the internet. And it's information about people who are involved in the PD study. There are many questions, and these questions are later answered by certain academic publications. As a clinician, my position is to understand the importance of difficulties in treating bipolar disorders. Even though bipolar disorder is accompanied by manic symptoms, hypomania and mania are indeed very important and integral parts of bipolar disorders. DSM-4, bipolar disorder is defined by manic or episode. Even though a person has never had a manic episode, we can call the patient a bipolar disorder because of DSM-4. Most of the patients have depressive symptoms. In the treatment of bipolar disorders, we have to assess the risk for progression to mania and what will happen if the patient becomes manic. We must understand the progression of the disease, and we're really worried about our patient. At the present, we're not in a position to clearly define the parameters of the treatment for this type of patient. Does the patient have additional psychosis? We can also talk about spectrum of bipolar disorder. Atypical depression, subsyndromal depressive symptoms, short-term depression, etc. are called soft bipolarity. This is a different concept. It's part of the spectrum of bipolar disorder. All these are confusing enough, and in addition to that, new concepts are coming into the literature. We're not talking about a clear homogeneous disease. I think it's a very colorful disease and highly complicated disease, even when you compare to schizophrenia. In this field, we have two medications. In the past, we were, of course, using lately, in the past 30 years, two drugs came into the market. One of them is olanzapine fluoxetine combination, the other is quetiapine. The use of antidepressants in bipolar disorder has not been studied very extensively. Sometimes antidepressants can cause a shift in the disease and maybe increase the progression of the disease. And STEP PD gave us some results. In the treatment of PD, we should avoid the use of antidepressant monotherapy. Lithium and lamotrigine were the popular drugs that we were using in the past. This is taken from the book of by APA. What can we do in the acute period? We can give olanzapine fluoxetine combination for prophylactic purposes. In bipolar type 1, lithium lamotrigine. In bipolar type 2, there's no prophylactic treatment, and of course the alternatives are here. Lamotrigine, lithium, quetiapine, and other antipsychotics. For prophylaxis, carbamazepine, valproate, sodium, valproate, olanzapine, or combination of carbamazepine and the other atypical antipsychotics have been mentioned. These are recommended for prophylactic treatment. Depending on the severity of the disease, you can classify the patients. I don't think all this brings any addition to our clinical information. This is what you do every day in your daily practice. You all know these concepts. For bipolar 1, there's no difference between bipolar 1 and bipolar 2. The treatment alternatives are almost the same for both groups. Do we need to add a mood regulator to antidepressants? Is it effective? A study from Amsterdam said it is not necessary to add a mood regulator in bipolar depression. Certain studies indicate that it is possible to give antidepressants during the depressive period, but the increasing number of randomized studies indicate that antidepressants are not effective. Antidepressants sometimes may trigger mania and rapid cycling, and therefore the patient may be in a worse situation. Multimodal antidepressants are now causing rapid cycling and also rapid progression of the disease. Antidepressants may also cause chronic irritable dysphoria. And American Caricot in 2005 have studied antidepressants, and they have classified a group of patients who are in chronic irritable and dysphoric situation. They have moderate insomnia, some loss of social and professional functionality. And it sounds like it looks like a depression. We give the antidepressant to the patient, but it's not effective. And when you stop antidepressant, the patient seems to be doing better. Elmarek and his colleagues in 2008 have published a study on STEP PD patients, and they have said that 1 out of 8 patients who were given antidepressants developed AKID. When you say an antidepressant, what do you mean? Is it the correct definition? Is it the drug that you give for depression? The word antidepressant now is beginning to be the subject of much conjecture and discussion. The chronic chronic situation seems to develop in patients who have been given antidepressants. You know that 85% of the patients who have received who have been given antidepressants seem to be doing much better. You know that you can use statistics in any way you wish. We have to go back to the patients, and we have to work on our own patients, on our samples. Just by looking at figures, you can be misled. All the figures that I have given you indicate the harmful effect of antidepressants. 85% of our patients seem to be doing very well with antidepressants. The development of AKI is related to gender, female gender, and mood disorders. What is an antidepressant? Antidepressants are to be given to unipolar depression patients for a limited time. For bipolar depression and for neurotic depression, antidepressants are either ineffectual or only partially effective. In step BT, the study, which was supported by NIMH, showed that mood regulators and antidepressants were studied in this major study. It's a highly extensive study. In this study, response to antidepressants and placebo seem to be the same. Antidepressants and placebo have almost the same level of manic shifting. Therefore, antidepressants are not really responsible. I wanted to show you a video. Maybe that's what happened. Can we see the video? In the study, the antidepressants were bupropion and paroxetine. This study allows the clinician to select the antidepressant that he wants. So it's not a fully controlled study, but a partially controlled study. Bupropion and paroxetine are the antidepressants which were selected. So the manic shift ratio could be low because of that. As a result, we can say that antidepressants seem to be ineffective or have limited effect in bipolar disorders. In complicated depressive situations, antidepressants do not seem to be quite effective, and we do not know the effect of antidepressants in pure bipolar disorder. Yesterday or the day before, Dr. Hüsner spoke about that. Bipolar disorder has a depressive period, or a unipolar depression patient is very rare. Most of the studies have to be carried out on these patients. The patients are selected according to their symptoms, but they usually have other symptoms such as anxiety. We all realize that the present studies have a certain handicap. I will briefly mention a study we carried out. I know it's not directly related to the subject, but in this study we used only atypical antipsychotics. The patient having even atypical antipsychotics plus mood dysregulators were compared to one another, and we were able to show that there's no difference between the two groups. There is no directly related antidepressants. There's no difference between giving antipsychotics or adding mood regulators. Our study indicated that very clearly. is our neurotic depression. Neurotic depression is not really fully in line with the definition of depression. People are now talking about neurotic depression. It's not episodic, it's not chronic, but it also has an anxiety component. So some people talk about neurotic depression. These are the diagnostic criteria. It's not really a full depression, but it is a neurotic depression, and we cannot really treat it with antidepressants because it might lead to further complications. In bipolar disorder, depression treatment is not very easy. You have to use systematic treatment, and if necessary, you will use medication for other indications such as schizophrenia, and we need new treatment modalities. If there is anxiety symptoms, anxiolytic agents are not very effective. In an uncontrolled randomized single-blind study, lithium and lamotrigine have been found to be effective. Subsyndromal manic symptoms increased relapse rate and relapse risk. There was a study by Dr. Sayed. Hostility and anger accompanying depression are indicators of bad progression. They could be manic, they could be also manic symptoms. We also believe that is why the patient does not respond to antidepressants. Maybe these are the masked manic symptoms. By adding an antidepressant to a mood regulator, you're not getting any effect. It's almost the same as a placebo. And the result is the same. There's no difference between them. A mood regulator is the effective medication here. It does not mean that antidepressants have no impact. In bipolar disorders, we know that adding a mood regulator is not really useful or effective. I will present a case now. We can discuss this case. Here you will see how antidepressants and antipsychotics together with benzodiazepine may have impacted this patient. I hope that you will discuss this patient with me. The patient is indeed a complicated patient, and I'm sure you're meeting similar patients in your daily practice. Therefore, I want to show it to you and discuss it with you. With your permission, I want to show this patient to you, and I think that we can discuss it and it will be very useful. I am sorry, here you see the name and the family name of the patient. I hope this is an ethical error. But we did get a consent form from the patient. Here you see the patient. I don't know why we cannot hear the patient. We need the sound. Did you have sound on the recording? Unfortunately, we don't seem to be getting this sound here. Okay, let me summarize. This is a 10-minute interview. I prepared a short version and it was really bad. I edited this video. It's a 10-minute video. At the beginning, this lady was expressing her anger. She was angry with her family and she had some problems at work, etc. Previously, she was diagnosed with depression, and and she was receiving depression treatment. Later, the physician discovered that she has bipolar disorder, and she was asked to go to a different center. So she came to us. The previous physician diagnosed her as bipolar disorder. The information we got from the patient, we saw that there was trauma as well. The score was about 27, and you know that 30 is cutoff point. She is not a dissociative disorder patient. She has syncope. And she's got bipolar disease. She is a bipolar patient. Did you have many such episodes? So let's follow the video. It happens almost every month. Are there periods when you feel you're unhappy? Yes, of course. Do you feel that you're not getting any pleasure out of life? Yes, I think about suicide all the time. I did make some attempts. I'm very unhappy. I'm angry with everyone. What about syncope? How do you faint? When I get angry, I really lose consciousness. I faint. I don't know what exactly happens. Can you hear when people call you? I'm sorry, the interpreters are not getting any sound. Translation is not possible without any sound. Now sounds back. I think we have to go back because the important information is we have to go back and start from the beginning. We don't really have any time. I'm sorry, we have to stop you. Let me summarize. The patient was taking Remeron, Tolmon, and anyway. These were the medications given to the patient. She was getting angry from time to time. She was unable to control herself. And she was having difficulty at work. And she feels that she's very unhappy. When you add an antipsychotic, quetiapine, at a low dose, and I think the Motrin was added, the patient is now feeling much better. But actually, the patient had chronic dysphoria, anxiety. She was very angry all the time, and she felt very unhappy, depressive. As you can see, this is a very clear bipolar disorder, mixed bipolar disorder. It's not bipolar 1, it's more like bipolar 2. So we treated the patient, and she's not doing very bad. She's doing quite well, actually. This kind of patient is the kind of what we see almost every day, and when we give antidepressants, you don't get a very good result. There are other cases that we have been treating. These are patients who are being given high-dose antidepressants, who are being given combined therapy, and all these patients also have anxiety. When we decrease the antidepressant dose and add antipsychotics, I think the patient is doing better, and that is something I observed very clearly. And when I used aripiprazole on the patient, I gave quetiapine. All these experiences are important for me. I tried almost all the antidepressants, and I could not treat my patients. Later, if the patient also had anxiety and if there were any manic symptoms, we treated the patient with antipsychotics, and we got very good results.